I had a number of questions about our company. We're headquartered in Edmonton, but we're in Calgary half of the time. Most of our business is in Alberta, but we do IMEs across Canada. And one of the things that I was talking to a gentleman about was a new service we're offering which is a tele-IME. So we now offer the opportunity for people who live in remote part of anywhere in Canada, the opportunity to have an assessment done by a top-tier psychiatrist. So that's a little something we're doing, and I think I just took that extra couple of minutes so that Dr. Hodkinson is ready, and this part's a lot of fun. So the last part of the afternoon, it's going to go pretty quickly. We're going to be talking about chronic pain and Waddell's signs and a few other elements. And at the end, again, I want you to please write down your questions, and we'll have some fun asking your hardest medical questions to Dr. Hodkinson. I think we're ready to go.
Thanks, Ken. I'm live? Yep, good. So I need a victim. And I promise not to beat you with this. Okay, sir. Yes. I promise not to cut you in two. Okay. Actually, if you wouldn't mind sitting before I dismember you. Waddell signs. A little note about Dr. Waddell. Famous, you might have heard the name. Dr. Waddell, and I think he's still alive, certainly retired. He's a Scottish orthopedic surgeon, and he noticed that after back surgery, there was often a poor outcome. And he was wondering, how could I predict a poor outcome of people having back surgery? And so he published a number of signs on examination that became known as Waddell signs, that if enough of them are present, and we'll talk about that in a minute, if enough of them are present, it predicts, not in an absolute sense, but it skews the outcome to suggest that the surgery would not be successful. And it became known as Waddell signs. The 5 of them, the first one is, I'm not going to hit you with this, I'm really going to put it down. It's intimidating. The first one is diffuse tenderness. It's just not normal or physiologically explained in any pathological process to have tenderness on light pressure all over the body. Yes, there may be reasons locally around the shoulder, perhaps, or bursitis over the hip, but not generally. It's not explicable in terms of scientific medicine. The second one is, I'm going to do this very gently, so-called axial loading. You put your hand on the person's head and you press down gently. And if that produces low back pain, it's simply not explicable medically. There's no way that gentle pressure on the head should increase low back pain. Distraction is it's a sneaky thing, but it's all set up ahead of time. But you're doing talking, whatever, and then just by accident you drop something, and you're supposed to look at that very quickly. There we go. It's quite surprising how people react when they're not really paying that much attention. Another one of a similar nature is the straight leg raising situation. Now, that's why we have 3 chairs. So would you mind lying down? That'll do nicely. Now, if I was to ask you, if you wouldn't mind, to bend your knee here, right? A little bit higher. All right, so he's bent his knee. And now I'm going to ask him, your legs just like that, to straighten your leg out. Okay? That, and now put it down again. That didn't hurt you, did it?
Sorry?
Didn't hurt you?
No.
You're supposed to say yes. All right, now compare that. We wouldn't mind sitting up now, please. Compare that with this situation where he's sitting down. Okay, this orientation of torso, thigh. Sorry? You lost the mic. I put it in my pocket. Is something detached? Is that any better? You can't hear me? Well, it doesn't matter. Can you hear me at the back if I just speak loudly? Yeah, okay. So this orientation of torso, leg, lower leg is exactly the same as it was lying down. And now I'm going to ask you to put your leg up. Now, if that produces pain and the other one didn't, or vice versa, it's a red flag because it's an identical anatomic movement. That's the third one. The fourth one is if there is global change to sensation over typically one side of the body. It's highly unusual medically in neurology to have a total change in sensation over one side of the body. We call it non-anatomic, non-dermatomal. It's not following the distribution of nerves. And the final one is perhaps the one where I need cooperation from the victim. So just a little bit of prompting here. So my gold standard for pain is an Italian woman in labor. If that produces the screams of an Italian woman in labor, that's highly atypical reaction to the appreciation of pain. Thank you very much for being most cooperative. Shit, I'm sorry.
That's it.
My apologies. So that's what else, the actual signs. Now, what do they mean? Well, it's more important what they don't mean, because they've got this reputation of being a sign of malingering. Dr. Waddell's very upset about that. He publishes about how upset he is that it's not meant to be a sign of malingering at all. 3 out of 5 is deemed to be positive for so-called non-organic findings, because none of those features are explicable in terms of medical science. But 3 out of 5 is definitely abnormal. But there could be many other explanations, and this is now where I switch to plaintiff lawyers to give them some sense of how they can interpret these things. It doesn't have to be malingering. Someone could be very anxious, maybe exaggerating their reaction, perhaps because no one believes me. I've seen so many people. I really am sick. Most of these people are not malingering. They are really in pain. They've seen lots of doctors, chiroquacks, as I call them, as well as other hangers-on in the industry. We'll talk about how many people are at the trough in a few minutes, but you'll have to wait for that. But, many people are desperate, and they've been led to believe that they're sick, and they are in pain, and they're now at this important IME. And, they exaggerate, because no one believes it. I really want to make people clear that I am sick, and so they exaggerate, and it's perhaps understandable. If you can't read that, it says, I get a real sharp pain when I do this. That reminds me of the old legal trick. You got someone on the stand, and the lawyer says to you, well, show me what you can't do. I can't do this. Let's get into the report itself. First of all, the generalities. It's not unethical to have a draft that someone has a look at, preferably not the client, because you don't want to be seen to be influencing the opinion. But one of my roles is to look at the report and function in a QA, QC capacity, never ever to change the opinion. Goes without saying, it's absolute no-no. It should be a unique style. There's nothing worse than a kind of cookie-cutter type of IME report. But more importantly, whatever the opinion is, whether it's for or against, it doesn't really bother me whether it's pleasing the client or upsetting the client. What is terribly important is that it's supportable, that it is plausible, that it all hangs together, and regardless of whether it's pro or con. The question should all be answered. Narrative is best. It should be based on evidence. It should be evidence-based opinion. The language should be clear lay language, nothing fancy that you have to go to the internet to figure out. You've got to stay within your area of expertise. One of my jobs is to make sure that orthopods don't talk about psychiatry and vice versa. It can trash your opinion, even though the rest of it's pretty solid. There should be no internal inconsistencies in the opinion. There may be a need for supporting literature if it's a contentious matter. For example, is there or isn't there a relationship between MS and trauma? We've had a few cases like that recently. And then finally, you get an opinion that's based upon the balance of probabilities. Doctors, unless they've done many IMEs, are unfamiliar with that term, because in medicine we don't think that way unless you're doing IMEs. Doctors don't think on a balance of probabilities. They think in terms of a differential diagnosis without considering how common each of them are, except the commonest one's at the top, and it's in a kind of a sequence of less probable causes. But it's never, medicine doesn't think on the basis of 51% or more. It's just totally foreign thinking. So you have to, the doctors have to be aware of that important legal yardstick, which doesn't come naturally. There has to be potentially an exclusion of pathological causes or a confirmation of pathological causes. There has to be cautionary use of investigations. Outside of the IME process, where people get MRI'd willy-nilly, in real clinical medicine, you never do an MRI unless it's going to influence the outcome. It's a decision point of surgery or no surgery, for example. If you ask for an MRI for low back pain, remember that 30% of you here without back pain will have disc abnormalities on your MRI. And you're walking perfectly normally, you don't have any sensory or motor problems. It's just because an abnormality is present on MRI doesn't mean to say it's causing the problem. It has to be correlated with the findings on examination, and the two have to support each other. So your X-ray showed a broken rib, but we fixed it with Photoshop. This is another example, subtext, the body heals itself, all right? The body is a wonderful organ, heals itself. There may be X-ray reports, nerve conduction studies recommended or interpreted, but at the end of the day, you're faced, if you're on the defense side of things, there may be suspicion about the honesty of the individual. Surveillance might be appropriate. Neuropsychological testing can incorporate symptom validity testing, which is a way of trying to numerically assess honesty. There may be additional IMEs needed, forensic psychiatric IMEs, for example. But at the end of the day, you get down to this general statement of balance of probabilities, 51% or more likely than not, whatever phrasing you want to use. And you get into these distinctions between exacerbation and exaggeration and impairment and disability. And I have in your handout a couple of graphs which I think are terribly important in terms of understanding disease process, degenerative disease, and the deep meaning behind these words, which are frequently interchanged, but do have precise meanings, certainly in a WCB setting. Sorry, we'll get into that in just a minute. Final thing on, I'm jumping ahead here. We will cover this in a minute. So far as the treatment side of the report is concerned, obviously you want to see whatever treatment is evidence-based. It should be active, it should be time-limited, no soft collar, it encourages sickness behavior, it should be market-priced, and there should be absolutely no, underlined in neon, no passive therapies, and the etc. goes on across the parking lot and the hills and over there. The number of passive therapies out there is as long as an insurance adjuster's willingness to pay. I call it a cancer in every shopping mall. It is pathetic, and it's part of the reason for that big B sign at the beginning. The billions of dollars that are wasted on rehabilitation. So we have various categories of passive therapies. This one kind of is about physiotherapy. How do I know you're just not pulling my leg? A lot of belief factors are involved in many passive therapies, but let's deal with the manipulators first. Passive physiotherapy, absolutely no place, except extreme circumstances like frozen shoulder, and you're trying to move something that, is really got bound up with fibrous tissue. But overwhelmingly to be discouraged because it makes the person have something done to them as opposed to them doing something to themselves. Passive physiotherapy. Massage, yeah, it feels nice. But outside of Olympic, quality athletes and the Oilers and all that, recovering from a game, it's not going to do a damn thing for you in terms of recovering from a whiplash-associated injury or any other minor sprain and strain. Craniosacral therapy. This is like witchcraft. This would have you believe that there's kind of an aura around the head that you can somehow sense, It's absolute hocus pocus. It happens. It's going on out there. Chiropractic, same deal. I got to be very careful here. They sue you. There are two kinds of chiropractors. There are those that are really physiotherapists, in which case, give me a break. Stop calling yourself doctor, You can't cure an ingrowing toenail by adjusting the spine. But there's another group of chiropractors that knowingly manipulate the neck, knowing full well the potential for stroke, causing a dissection in the vertebral artery as there's a twisting and pulling motion of vessels that go right through the bone here to the back of the brain. There's a very brave neurologist in Edmonton, Brad Stewart is his name, who, with co-authors for safety, got an article published in the biggest American journal, JAMA. And they showed, it just happened to be in Edmonton, but it was an international paper. They showed that the incidence of stroke following chiropractic neck manipulation of the classic type produces stroke at a frequency of 10 times what the chiropractors claim. Why we still allow this to happen as a so-called regulated therapy is beyond me. I mean, it's just grotesque. And there's a digression here, because I mustn't get on a soapbox about this. But do you know how all this started? It's absolutely amazing how all this started. Mr. Palmer was a Canadian who went down to the States, and he couldn't make a living selling, look it up on Wikipedia, and all this is true, all right? He couldn't make a living selling magnetic bracelets. Surprise. And he actually dreamt up this stupid theory that somehow the alignment of the spine is causing all these diseases. It's beyond ridiculous. He didn't do that well until his son started the first so-called school of chiropractic. And then it took off and it mushroomed and it's all over the place now. It just staggers me that our regulators and our... See, one of the reasons this happens is that people are desperate. People have pain, and traditional medicine is not impotent. We fail many times, more often than not, perhaps. We don't know the cause of 90% of low back pain. Anyone that says they do is a liar. Hamilton Hall missed the back pain, started CBI. That's what he says. We don't know the cause of the vast majority of low back pain. We call it mechanical back pain. No one knows what the hell that is. It's just a label. It has no pathological correlate. Why this is allowed, I really can't say. People are desperate. Traditional medicine has failed. They go to a white coat. Chiropractors are trained in marketing. Did you know that? Doctors aren't. Chiropractors have formal training in marketing. They have to have, because it's nonsense. But they know how to sell. They're in a white coat, and they talk a good line. And these are desperate people. So who's to blame desperate people from trying anything that's out there to get better? Because traditional medicine has failed them. Who's to blame? Who's to blame them? You can't. They're just like lambs to the slaughter. The other reason it exists is because they threaten people that berate them. The American Medical Association had a major lawsuit with chiropractics in the States and lost. That's very sobering, is it not? Also, judges and cabinet ministers are also ordinary people in their medical lives, and they see chiropractors. So they've got friends in high places, and they continue to exist. This is a good one. If any of you that have seen their recommendations. I had a great time tonight, and I'd like to see you again 3 times a week for 6 weeks and twice a week for 8 weeks. You might say forevermore. We had a report once from an orthopod who was commenting on a chiropractor's recommendation of treatment for life. And he said, I'm not quite sure who's going to die first, the patient or the chiropractor. And then we have the stimulators. Good old galvanic stimulation. He lived to tell the tale. I'm not sure if it got him any better, but it must have been a nice tingling sensation. TENS, it's everywhere. All these things are what I call fervently held anecdote. They're allowed to happen. The practitioner believes it works because of his or her own experience and sells it on that basis without any serious general agreement that it's evidence-based and effective. Personally held anecdote is how a lot of this stuff gets out there and happens all the time. TENS has no convincing evidence that it works. Some physiotherapists think it does, many of them think it does, but there's no convincing evidence that it works. The needlers. Let's move on. They can be pins, they can be needles, or pins and needles. Take your choice. And that includes dry needling. Absolutely ridiculous. How could that possibly cure anything? Prolotherapy. This is going on everywhere too. I'm not exaggerating. This is serious stuff. This is happening everywhere, all right? Prolotherapy would have you believe that if you inject a sclerosing agent, something that creates inflammation and fibrosis, around a joint, that it will stabilize the joint and stabilize it and therefore make it less painful. It's invasive. But there's no reason why it should work, because what this sclerosing agent does is just hypertonic saline or hypertonic glucose. It induces an inflammatory response and therefore fibrosis, but the fibrosis is not organized. For fibrosis to be effective around a joint, the fibers have to be parallel. It has to be something that creates a tough barrier. All that prolotherapy does is introduce a sort of vague area of little bit of collagen where the fibers are all over the place. You might as well, it doesn't stabilize anything except the practitioner's bank account. And this is an exaggeration, but it's for effect. You know, you need multiple injections over a period of time. Each one's a billable event, and that perhaps is the problem. People can make money out of it. Acupuncture, similarly.